Hello, my name is Reid, and I'm the Director of Cancer Screening and Survivorship at Roswell Park Comprehensive Cancer Center, and I'm going to provide a brief update on lung cancer screening. There are a few barriers that we've recognized since lung cancer screening has been implemented. One is that only 4% of eligible people across the U.S. have taken up lung cancer screening. In rural areas, that may be even less, closer to 2%. So why is the uptake of lung cancer screening so small? I think there are three primary barriers to uptake of lung cancer screening. One is that the physician community or provider community has not been properly educated about the nuances of lung cancer screening, who's eligible, which are the best patients to screen. Sometimes they have very large numbers in practices, especially in primary care practices, who are eligible, and it's hard to sort out where to put the focus. The second barrier is that nodule management is very complicated. If you're not used to it, you sometimes don't understand which patients need more intense surveillance. While radiology gives an opinion about the time frame, that time frame of when the next CT should happen is often complicated by other clinical factors that the patient has. And so this nodule management really needs to be clarified. We need to mobilize resources in each community so that people are working together and making decisions about which nodules need intervention. And the third is the penetrance of centers that are actually doing lung cancer screening. Particularly in rural areas, patients can drive up to 2 hours to get a center that is registered to do lung cancer screening, and this is definitely a barrier. How did lung cancer screening come about? And it was through the National Lung Cancer Screening Trial, or ENLIST, that was published in 2011. The ENLIST trial was a randomized trial that compared low-dose CT and chest X-ray, and with 3 annual screens looking at a reduction in mortality from lung cancer of low-dose CT group compared to the chest X-ray group. There were also secondary endpoints concerning all-cause mortality, again comparing low-dose CT with chest X-ray. The study was a randomized clinical trial which provides the strongest evidence in proving efficacy of a test. It involved over 50,000 individuals, 55 to 74. They had to have a smoking history of at least 30 pack years. Again, 1 pack a day for a year is 1 pack year. So people essentially smoked over 30 plus years. They had to have quit within the last 15 years, and they were randomized to either the low-dose CT group or the chest X-ray group. Now, what we knew going into this trial was that chest X-ray had already been shown in several clinical trials not to have a significant reduction in lung cancer mortality. Now, with the CT can pick up a much smaller lesion, sometimes as small as 2 millimeters. Whereas chest X-ray, historically, we know it requires a much larger lesion. And oftentimes when a lung cancer is picked up on chest X-ray or is finally visible, it is already in a later stage or metastatic. So what the ENLIST trial showed us was what we expected. There were more cancers detected in the low-dose CT group, 649 or 3.5%, compared to the chest X-ray group of 279 or just 5.5%. So the actual number of lung cancers detected in the low-dose CT group was greater. But we can also see that the mortality benefit of low-dose CT was seen within the first 2 years of the trial. And by the time the 7th year of follow-up and the study ended, there was a significant reduction, 20% reduction in lung cancer mortality in the low-dose CT group compared to the chest X-ray group. We've seen the same results in the Nelson trial, which was unveiled this fall in Toronto, where they showed a 26% reduction in low-dose CT screened individuals compared to chest X-ray. Currently, the majority of lung cancers are diagnosed at stages 3 and 4 when surgery is oftentimes not an option, and there is no potential for actual cure. This is the current state of lung cancer diagnosis. We found that from the Enlist trial, and again, other trials that I'll mention further in my talk, that with screening with low-dose CT, you see this shift to the earlier stage where patients can potentially be cured. 55% from the Enlist trial actually were in stage 1 or 2, which offers the best survival benefit. You know, for the first time, really, that the Enlist trial results came out, we could definitively say that diagnosing lung cancer at an earlier stage offered an improved survival over time. And this is, again, compared to chest X-ray. There are several limitations to screening. One is the rates of false positive. We know that from the Enlist trial, of the nodules that were biopsied, 96% were benign. So our ability to actually tell a nodule whether it's cancer or not is really limited. And there were a lot of interventions that showed a benign lesion. This was highest in the patients who met the minimum criteria of risk. So the false positive rate was related to often the level of risk of an individual. If they came in with the minimum qualifications, they had a higher false positive rate. There are comorbidities from interventional procedures. There's been some recent papers talking about this. In the Enlist trial, all of these sites for the study were in tertiary care centers where the comorbidities from biopsy or surgery are very low. When you push lung cancer screening out into the community, you can't be assured that this rate of side effects from biopsy would be as low. And the third thing that limits the uptake, particularly with lung cancer screening, is the burden on primary care providers, primarily in communities. Close to 85% of patients who meet the criteria and are screened will have at least one nodule on their CT. And while these nodules may be small, it still requires additional follow-up monitoring by the primary care. So in a practice where you may have 500 patients who are eligible for low-dose CT screening, this is an added burden. Now, the United States Preventive Task Force set the minimum criteria for lung cancer screening at 55 through 79, and again, the upper age limit may be dependent on the insurance providers, 30 or more PAC years, and quitting within the last 15 years. Now, the advantage to lung cancer screening being rolled out through a very large clinical trial is that we could go a step further and determine which segments of the population or the patients in this study actually conferred a higher risk for lung cancer. The risk of lung cancer was not homogeneous across all of the subjects recruited into the trial. Through some very, very creative risk modeling done by Martin Temamaji at Brock University in Canada, which was validated in the PLCO trial in 2012, showed that there are variables that actually provide us with some ability to tease out who are the higher risk people for lung cancer. And these variables here, including age, how long people smoked, how many cigarettes a day they smoked, the cumulative PAC year exposure, if they're continuing to smoke, they have a family history of lung cancer or a personal history of cancer, all increase risk of lung cancer. And as you focus on this increased risk of lung cancer, you can start to drive down that false positive rate. There are some variables, however, that decrease the risk of lung cancer, and those include a higher BMI, a higher education, which is also a surrogate for smoking, and years since quitting. Those behaviors actually decrease the risk of lung cancer. Now, why does this become important? So in the Temamaji group, they split the Enlist trial participants into 5 quintiles, and those quintiles were based on risk, primarily looking at age, PAC years, years since quitting, the presence of COPD or obstructive pulmonary disease, first degree relative with lung cancer, and body mass index, and mapped out the lung cancer deaths that were prevented from low-dose CT. And you can see the trajectory. Here's the lowest quintile, which is the minimum requirements of 55, 30 pack years and quit within the last 15 years, to the higher quintiles, where you really see the benefit of lung cancer mortality prevention focused. And those, again, are in the people who carry the most risk factors for lung cancer. There was a pan-Canadian study on early detection, which was across the country of Canada in 8 clinical sites. 2,500 people were recruited. Again, the age, smoking duration, pack years, family history, education, BMI, chest x-ray within the last 3 years. When you split people up according to risk, you found that there was a higher cumulative incidence of cancer in this group as opposed to the Enlist trial. So this is essentially a study of those higher risk individuals. 77% of cancers diagnosed in this study were in stages 1 and 2, compared to 57% in the Enlist trial. The cost effectiveness of low-dose CT screening has been examined in many studies. And in the latest one by Kumar et al., published in 2018, they described that when you begin to apply the PLCO model, you have to screen fewer people, a decrease of 8.8%, to detect more cancers, an increase of 12%. So again, it dramatizes or proves that if you focus on these higher risk individuals, you have to screen less to get more cancers. Now, most recently, in February of 2019, the Temamaji group again published a study looking at these highest risk individuals, but also incorporating the results of 3 low-dose CT screenings. And they considered a positive screen a low-dose CT that was rated to have a lung RAD score of 3, or essentially a 6-millimeter nodule. And the positive screens show an 8.9% or 9-fold increase in risk of lung cancer when you actually look at the results from low-dose CT. This group represents people who had at least 2 positive CTs, whether it was the second and third, the first and third, or all 3. So again, as screening is taken up, someone with a positive CT who continues to have a positive CT over a series of screenings are in that group of highest risk. And again, this conferred an 8-fold increase in risk compared to people who had no positive CTs. So again, as we struggle with time and the burden of doing CT screening, we would best be served by focusing on the highest risk population. Again, what are those characteristics? We're looking at people with a 50-plus pack year exposure. And in some regions of the country, these people are quite numerous. In our area of Western New York, we have very high smoking exposure rates in rural areas. As high as 30% of adults are active smokers. Current smokers continue to be at increased risk regardless of whether they're screened. And of course, if you can't get people to quit smoking, you need to adjust their risk assessment to the fact that they're continuing to smoke. People who smoked 1.5 packs of cigarettes a day. People who've quit within the last 10 years. People who have a moderate to severe COPD measured by an FEV1 of 70% or less. People with a positive family history of first-degree relatives with lung cancer, a low BMI, and in the latest models showed a history of pneumonia. Now, these are the NCCN guidelines, which very in great detail articulate what the follow-up should be, how we evaluate what's a low-risk individual versus a high-risk. And overlaid with this is the lung RADS scoring. So these are, lung RADS is very much in line with the NCCN guidelines, which are available online. And they really mark out whether you have an 8 or 6 or 15 millimeter nodule, what the sequelae in terms of screening should be. So what are the nodules that are diagnosed on a low-dose CT that should draw attention and special management. And this is where communities must start to talk to each other to determine how to manage nodules which put an individual at higher risk for lung cancer. These are lung RAD scores of 3 or more, which again represent approximately a 6 millimeter nodule. Any nodule that is growing should draw specific interest. The reports from radiology should demark the nodules, where they're located, and the change in size. A new nodule. So we already know from follow-up studies that people who develop a nodule between screenings that is 6 millimeters or more, or change from 5 to 6 to 8, those confer a dramatic increase in risk of lung cancer. Solidity of a nodule should be commented on in the radiology report. And again, solid nodules that are 8 millimeters to 1.4 centimeters, or semi-solid nodules that are a centimeter or with a solid component greater than 5 millimeters confer an increased risk. And those are nodules that must be tracked from CT to CT by the radiologists. And ground glass opacities, which have been sort of an anomaly, but we now know that ground glass lesions that grow in size up to 2 centimeters confer an increased risk and require additional surveillance. Thank you very much.